When I was given this topic to discuss MRI for family physicians, the first thing which comes to my mind, especially with an intent that you are given an option that teach them how to read MRI. And when you give a topic which is an open-ended topic, which means MR of the total body, it is impossible to even touch how to justify indication or referral base for MRI, leave alone teaching how to read MRI. So when I'll start, if I start, we're looking for a laptop. Once we have it up here, then we'll get going. I will talk mostly about justifications and share examples with you of different areas as to why and when we really require MRI and where it might become useful for you and your patients at a primary care level to be referred for MRI. MRI now has advanced to a level where you and I really cannot even imagine our practice. The problem is more of application of MRI rather than the actual equipment availability or the hardware. One of the best MR subsets or machines are nowadays available in public hospitals, not in private hospitals. The public hospital machines are way beyond our imaginations when we started with MRI. They are providing a good baseline service, which is adequate, but the objective of getting high-end machines was to upgrade your applications and the service provision for the departments, particularly of the subspecialty departments in public hospitals. But unfortunately, this marriage or expectation has not been fulfilled. That's my personal judgment. Others, my colleagues, particularly who are sitting over here, who belong to radiology, might disagree. But we, as part of the Radiologic Society of Pakistan, feel that we are not providing the service which we should be providing in public hospitals. And I'm just repeatedly saying public hospitals. And the reason being the marriage between radiology department and the clinical services in all the hospitals. It's not a perfect marriage. No marriage is perfect. You have to make it work, but this is not clearly a good marriage. We need smart clinicians. That's my feeling. And what do I mean by smart clinicians? Clinicians who know and expect and demand more from radiology and or for that matter pathology department. When we started off, we only had available X-rays, contrast studies. That's how radiology was being practiced. So there was much more demand from the radiologists to deliver on those two modalities. When ultrasound came, the choices were more. And now that we have a battery of choices, the demand has kind of stagnated. The use of MRI has increased tremendously, but it's basically at the grass basic level where we are utilizing the MRI. So I'm going to share a few things once we get going. As I was saying, MRI can be utilized for the whole entire body. And in fact, all system MRIs can be performed. I do not know of any system which MRI does not have a utilization for. Let's start off with the brain, right at the top. All ages can be scanned. There is no reservation. The only absolute contraindications are having metal which cannot go into the MRI, whether be it is because of the pacemaker or because of non-compliant or non-paramagnetic MR compatible prosthesis. But most of the prostheses nowadays being utilized in our clinical services are MR compatible, so that is not an issue. One question most of the people do ask that this patient has had a coronary stent placed, would it be possible for him to have a MRI of the head or lumbar spine? And then the next question which follows through is the stress on bare metal stent being placed into the heart. So that means it's something which is very paramagnetic. And the practice is that now all metals are MR friendly, so there is no problem with any of the available stents. Then the next question would be that this patient has had a stent placed or parked about 10 years ago. Would that be a reasonable thing and safe practice to place him in an MRI? Even then it's not an issue because they become epithelialized and they do not. And the problem with the older versions, 2 decades ago or so, was that they would only heat up when we did not really try them out as to whether they were MR friendly or not. Same stands true for the metal work which is done in the, which is placed in the spine or in the hips or in the skeleton. We all feel that this probably is not worth our while to place these patients into MRI because one, they give a lot of artifacts, and secondly, we don't know how it will behave. What happens to these metal components inside your body? The magnet, when it pulls up, it actually causes traction. More than that, it is the RF beam which hits the metal, which heats it up. That is what is more relevant and dangerous rather than actually simply placing the person in the metal. If you have a bed or a metal which is not MR compatible, then the patient will feel the pull and push as he enters the MR room. You don't have to place the patient inside the MR. It's only when you enter the room you start getting that pull. You have that feeling. And I don't know whether you've ever gone into MR examination rooms or not. The MR will pull the buckle on your belts if it is made of non-paramagnetic metal. And this is a very good test that it is working and the extent where it's working. So you can actually test out the safe zone for your MRI. I'm sure all of you know that there is no match to assessment of an intracranial lesion, majority of the intracranial lesions, when it comes to use of MRI. It cannot be compared with CT nowadays because of the battery of tests which are available in MRI, unlike the CT scan. But CT scan still has not gone out of fashion. It has made a resurgence, it's come back, and I'll share the actual justifications from a couple of tables for use of MR and CT and why one against other. The other reasons are mostly related to stroke, which I'm sure you as family physicians probably are the first people to come across. When people have weaknesses, where do they go? They call the nearest doctor, and the family physicians are the first step of call. And the assessment of these patients for stroke, I'm sure you will see that or hear about it in different neurology talks later on. But the primary factor which you apply in stroke is basically to see if there is hemorrhage or not. The deficit or the presence of the stroke is a clinical judgment. It's nothing to do with the radiology. You know the stroke has happened. You know the brain attack has happened. But what to do next is much more relevant. So if you have an arena where you can refer the patient to a stroke center, how many of you know whether there is a stroke center in Lahore or not? So I've got 2 hands up, and may I ask, do you know where? LGH? When was the last time anybody referred a patient to LGH for stroke center? Right. So basically what we need to learn and educate ourselves about is how to handle stroke. So LGH, while functional, has a stroke service in the sense that they will probably cater for a patient which comes within the actual opportune time of 3 to 6 to 9 hours, depending how much deficit they have. But as a proper stroke center, we do not have a service practically available in Lahore. Everybody is trying the best to offer a stroke service, but it is a lot of strain on human resource, and that's the reason I have my doubts that it will ever catch up. The service which I'm not supposed to highlight in a journal physician, but is basically built up by 3 neurologists in National Hospital, and they have developed a scenario, well, in fact, in Hamid Latif Hospital by another neurologist. So up front, you have to have a neurologist on the team. And you need to know how to get this patient processed within an hour so that you can start systemic or local treatment. But for that, all of you need to educate yourselves as to how to handle stroke in time. Time is money. It's 1 million a second. That is the scale of loss of neurons. But CT still remains the best tool, the easiest tool to decide whether the patient has hemorrhage or not. And the next move is to use TPA. Majority of these stroke patients will live and become a burden on the community, and that's where we need to focus. And we do not have anything to offer them as to how to resolve their morbidity later on. So as far as stroke is concerned, it's a very complex thing, and it's not yet there as it is. So we need to work on that. I think GPs should, our family physicians should actually demand that more proper stroke centers for referral should be developed. Because TPA is now available in Lahore, in Pakistan. Everybody uses it. If TPA was supposed to be used in coronary care, everybody would stock it. But it's a very expensive drug and it expires very quickly, so people don't stock it much. Those who have it are waiting for stroke patients. So MR angiograms are a later thing in stroke patients, not up front. Stroke is managed peripherally, primarily. Everybody gets TPA. Whether they need endovascular treatment or not, yes, that's where LGH comes into action, and Umair and team have got a setup for that purpose. But the primary care is with the TPA of stroke. The third thing is doing a complete workup in these patients who have stroke symptoms involving the aortic arch, all the major vessels, all the way up to circular villus. So you know what level and which level of abnormality you are going to treat, if there is any. The other main common indication for MRI is headache. And I'm sure that's what gives you all more headache than anybody else. The headache doesn't go away, and that's what brings back the patient all the time. So we know, this is from Mayo Clinic, the segregation of headaches is into primary headaches and secondary headaches. And this is a long list which I'm not going to go through, but obviously we know migraine remains at the top of primary headaches. And this is what we image for. Should we image these patients or not? That is a very big question. I'm sure you would want me to answer that question as well. And it's only in a certain subset of patients who have chronic, prolonged, long-acting, worsening, unexplained headaches where you would actually image them. Not every patient with migraine who you have clinically diagnosed. But then again, from a family physician point of view, anything which is recurring and worsening, that is the basic concept in imaging. You have to satisfy either the patient or give a negative outcome of your imaging attribute. But secondary headaches are mostly imaged. And why? Because they are either related to trauma, either related to vascular disorders, or even non-vascular intracranial disorders. You can appreciate that over here. They can come with worsening headaches, as I mentioned, with infection because it progresses, or you can have disorders of hemostasis, so subdural hematomas and stuff. The patients might be stable and all of a sudden they would deteriorate and come to you. Or they would have problems with eyes, ears and nose and other things. But non-specific cranial neuralgias do not really require any specific imaging. Now this is the table which I was referring to, why MR is preferred over CT and why, and where there's a draw between MR and CT in these circumstances. You can see that for vascular diseases, MR is preferred. Same stands true for neoplastic diseases. If you are suspecting, following up, or even anticipating neoplastic disease, MR would remain at the top. Same stands true for infection and or malformations, which are related to either Chiari or CSF flow, and intracranial pressures might be the cause of headache. CT is preferred mostly for trauma, so fractures in acute state, acute hemorrhagic, subarachnoid, or intracerebral hemorrhages. So these patients will either present with stroke or without stroke, but they have a peculiar, typical thunderclap headache, which will force you to refer them for CT more than MRI, and you want done something very quickly. So CT is much more quicker than MRI for unstable patients. And same stands for paranasal sinuses and other diseases. CT is mostly used and preferred by the clinicians who eventually will offer them surgical intervention. But there's a draw between MR and CT when it comes to angiography. So it depends really how the practicing radiologist and the practicing neurologist or neurosurgeons are happy or confident in using one over other. So you can do either MRA or CTA. Quite a large patients, the number of patients would not prefer to have contrast or cannot have contrast for one reason or other. They would obviously have a preference for MRA, and that's where we refer them. One thing more which is relevant over here, with the advances in technology, the comeback for CT is based on the spatial resolution it can offer. The spatial resolution of CT still is far exceeding than what we can get from our standard MRs unless we acquire volumes. Volumes can bring it down. What do I mean spatial resolution? I'm saying that people are losing interest in my talk. Spatial resolution basically means that you have the ability to distinguish between two points which are in close proximity. So CT could not tell two different lesions as apart, unlike MR, but it's made a comeback, and now it has a resolution which is now down to 0.23 millimeters. So practically 1/5 of a millimeter. That's how you can decipher that these are two separate things lying. So that's where it becomes much more helpful in defining the aneurysms. But both can be used, MRA and CT. Same stands true for the carotid or extracranial workup. And MR venography is much more easier to do and much more robust a test with a good reproducible accuracy than CT venography, but you do it in any case. And same stands true for the remaining venous assessment of the intracranial circulation. So this is how we decide upon MR versus CT, at least as far as head is concerned. Now this is a very complex table. I would not want to go through the whole lot, but this is again from Mayo Foundation, and this is the recommendation from them as far as management of headache is concerned. So if you have a comprehensive history in hand and you've done the neurologic examination, you can classify headaches into uncertain headaches, known or suspected primary reasons already documented, and this patient would have headaches, or thunderclap headaches. And that's what I said about thunderclap headaches. These are urgent things, and you are suspecting something acute happening, and mostly related with subarachnoid hemorrhages or intracerebral hemorrhages. These are the ones which require imaging more than anything else. Same stands true for the areas where you know a primary. So if you have a lung tumor and you want to image this patient, you can have either CT or MR, but majority of the institutions, tertiary care institutions, will prefer MRI to look for metastatic disease rather than CT. And reason is obvious, because MRI will pick up more lesions, decide on whether they are metastatic or not, or are there any other pathologies which can be labeled as dual pathologies. So MRI in all respects does better. That's why with known primaries you would do assessment with MR. But when you have yellow flags and red flags of uncertain headaches, you mostly follow them up and flag them till you actually require imaging. And you can see that imaging is basically based on acute changes within the behavior of the headache. So it's a complex thing. Headache is something which people do fellowships on for 2 years, still nothing can be done about it. So this is something which I'm trying to show off by telling you that we can characterize intracranial hemorrhages and strokes better than what we could do before. Same stands true for imaging of the cranial nerves. MR does far better than what CT can offer. Similarly, given the multiplanar component built in to CT or MRI, you can now decipher the exact location and do better planning for management, both surgical or non-surgical, in intracranial lesions. For smaller lesions like pituitary adenomas, CT used to be the baseline workhorse for us, but now it's practically obsolete. Pituitary is imaged only with MRI, and that too with contrast. Without contrast, there is no point. So it can actually show the pituitary adenomas, whether they are small like this into the one hemisphere of the adenohypophysis, or is it large like this, where it's actually compromising the optic pathways. The other common indication is back pain. So when do you image or even do an X-ray? This is again a we can do a single half an hour session on back pain. That's why I was saying it's very complex and difficult to cover MRI in one go. Back pain imaging is very difficult to understand, and it varies from center to center. I would actually address all of you not to send patients for lumbosacral spine X-rays, AP and lateral, without justification. Think of these patients just like your own kith and kin, because the radiation dose is extremely high, and nobody now has a justification to do an X-ray of the lumbar spine without severe justifications.